now we've got Dr. Edward Boyer, who is a professor and director of toxicology at the Department of Emergency Medicine, also at University of Massachusetts Medical School. And Dr. Boyer's going to speak to us about the prescription monitoring programs.
Yeah, so I didn't know who I would be talking to today exactly. So if you help create a prescription drug monitoring program, or if you've done research in it, this is going to be beneath your level of expertise. I adopted more of a global approach with it. Also, with the federal government moving things around and my slides being modified, you know, I didn't know who would be speaking before me or after me. So basically, I think I get a free pass with this talk. I can say anything, and it's not going to be my fault. So I guess I do have some conflicts. I'm an NIH-funded investigator. I've done a fair amount of work in substance abuse, including opioid dependence. I also review documents for medical legal review from a number of different insurers, probably in your state. So I've got objectives. Those are the objectives. So the first thing I'm going to go over is a bit of the rationale behind prescription drug monitoring programs. You know, I don't think it's any secret to anybody at this point. You know, we know that the volume of opioids has increased dramatically in the United States in the last few years. And it's interesting for me, a few years ago it was like, shh, don't mention JCO as the cause of all this. And now I think, you know, like, a bunch of people have begun to realize that JCO really was kind of the cause of all this. There are other things that had to happen too. There had to be Portnoy and Foley, who came along and said, oh, you can treat opioids, you can treat pain with opioids, and people will not get addicted. So there were other things that had to contribute. There were other things that had to happen. But ultimately, you know, like, we now have a lot more opioids. Part of this was also the extension of chronic pain management oncologic chronic pain management into non-cancer pain management. But at the same time, the number of overdose deaths has correlated, or at least moved in tandem with the number of opioid analgesics. You know, because we've gotten to the point where 98% of, what is it, Lewis? All oxycodone prescribed worldwide, consumed worldwide, is consumed in the United States, not North America, not the Western Hemisphere, but here in the U.S. You know, we've seen a rise of opioid deaths along with it. So the PDMPs, you know, like, arose from this balance of, you know, like, how do you, you know, like, prevent from undertreating pain while at the same time overtreating life. You know, like, we have to figure out. This was a mechanism, hopefully thought to be an effective one, that would allow us to better focus our opioid prescribing into select populations that would deserve it, while protecting the public health and keeping people from dying of overdose. A lot of folks might be surprised to hear that the legislation supporting PDMPs is not all that new. It's 20 years old at this point. But not surprisingly, back in the 1990s, we didn't really have the internet in as robust a form as we do now. So you know, when you look and you consider the effectiveness of paper PDMPs, you have to send something off, you have to wait for a bit. It's not surprising that emergency physicians were not dramatic or striking consumers of the information that PDMPs offered before web-based programs began to appear. Now, I guess when I think about, you know, conceptually about what they do, they can potentially simplify your clinical decisions. I mean, if you have somebody who comes in and says, Doc, you got to give me a lot of meds, and you can say, aha, you know, like, this document says that you've gotten from 18 different prescribers over the last 30 days, and you've received more than any human should possibly be able to survive. You know, like, you've now got a way out. It's a hatch that we as emergency physicians can dive through to justify clinical decision making, and do so in a rather rapid manner. I'll come back to rapid in a second. But it's a way to simplify our clinical decision making, or at least our sales pitches to patients. Because ultimately, you cannot rely on history and physical examination in evaluation of people with chronic pain. Every single one of us in this room has been lied to by a patient with chronic pain. I use that term advisedly. I know it's not the politically correct thing to say. I could say there's been distortion, there's been prevarication, there's been, you know, maybe miscommunication, but every single one of us have been outright lied to. And one of the latest cases where somebody came in and lied in our emergency department, it cost one of my partners, or at least our insurance carrier, almost $2 million. There's money and time and other costs associated with this. And PDMPs, are a way that we can approach these patients. Yeah, it's in terms of offering an alternative. I think it's because a lot of what the pain management apparatus, the whole pain management enterprise has generated is kind of an antagonistic relationship between patients and providers. There are pain contracts. I'm going to prescribe this medication. You will adhere to what I say. If you tried that in the HIV, a lot of my research is also in antiretroviral adherence. If you tried that in the HIV treatment community, you would be booed out of meetings. But in pain treatment, that's a perfectly acceptable clinical approach. There's drug testing that we can inflict on patients. You will submit to drug testing, otherwise you're out. And that's because there's a difference that arises. In the addiction treatment world, addiction views relapse as just part of the disease process. You're expected to relapse. So you do drug testing to find out if you've been compliant with therapy. If you're not, you need more stuff coming your way. You need more stuff in the terms of cognitive behavioral therapy and other interventions. In the chronic pain world, you have a urine drug screen, which is at variance with what your contract says, and you are out of luck, and now you got to go to the emergency department to be treated. So PDMPs can create opportunities for us in this setting. If we find somebody who comes in who has an awful lot of prescriptions written by an awful lot of providers, that's an opportunity to intervene. If you have somebody who's getting a lot of opioids and getting a lot of benzodiazepines, and maybe they've got some Flexeril and some other stuff that's lumped on board, it's an opportunity for you to prevent adverse effects. You can prevent bad things from coming to the patient. You can prevent bad things from coming to you. And it allows introduction of objective findings. How many of us have had to justify our clinical knowledge with, against that of Wikipedia? We just aren't believable, and if we can point to a piece of paper that's downloaded off something, then okay, it's objective. Take that. We can move forward. So I'm going to talk very briefly about the function. Hopefully everybody here has been on a PDMP at this point. But the PDMP, nowadays, they're largely online databases. They're online databases of drugs which have been prescribed. They relate to different schedules, but usually they're the abusable drugs, things that can be diverted for non-medical use. Data often comes from a single state. I'm going to come back to this in a second. For those of you saying, but I belong to one where there are multiple states. Generally, your data comes from one state. Data is nominally entered upon prescribing. There's some thought, dispensing. There's some thought applied to it. Do we want to enter data in the PDMP when people get a prescription, or do we want to say it when they actually get the drug? And it's when people get the drug. There's controlled access. That's related to the last bullet down there. Controlled access, you don't want just anybody getting on the website and finding about somebody's prescription drug history. There's information about the drugs they prescribed as well as the person who prescribed them, and then there are usability features in PDMPs that have to bring them into concordance with federal regulations about privacy. So I'm going to talk a bit now about the shortcomings of them. They're online databases. Fantastic. You can access them from any place, conceivably. You can best access them from a desktop, something that's hardwired. Not many of them are that robust in terms of being moved to a mobile device, which is where a lot of us are now moving our electronic data records into. So there needs to be an advancement to bring them in concordance with the mobile devices that we all use. That costs money. There's also a cost of maintenance. Somebody's got to enter this data. It's money, money, money. And these things are not, in all honesty, all that cheap. Data comes from a single state. There are a number of different states. We've also got, I want to apologize. This is 2 years old, but this is the most recent map of PDMPs that I could find that was of high enough quality to bring up. So yeah, we got the 50 states, but there's also Guam lumped in there if you also want to take a close, really close look at the map. But all the data is unique to those individual states. You can get information from your neighbors, but you're lucky if you can do that. There's a consortium of 20 some odd states which you can draw data from individuals. We live in New England, so we get people in our emergency department from Rhode Island, Connecticut, Vermont, and New Hampshire, as well as Massachusetts. And we can't share with the groups around us. So there's, like in a place where people can conveniently drive from one place to another, there's not that much coverage, but 20 states, I don't know how that map is drawn, but you're talking about a couple of days travel potentially from one site to another. So there needs to be better integration among all PDMPs before it really becomes good. There's also some vagaries of funding. Not every place funds these as consistently as they should. In Colorado, I think. Anybody here from Colorado? So do you know what happened with the PDMP there?
Almost shut down.
Do you know why? One of the legislators brought in a poor, long-suffering chronic pain patient to talk about how the most evil PDMP had denied her pain relief. And upon hearing of the plight of the chronic pain sufferers and how they weren't getting their narcotics, they decided not to fund it. Do you know who funds it now? Purdue Pharmaceuticals. Purdue Pharmaceuticals manufactures OxyContin. So thank you, Purdue. Good luck with that. Is that not totally correct?
No, they bridged it.
They bridged it. Okay.
Nonphysicians did.
Okay. So anyway, yeah. So good. Caveat emptor. Anyway, data upon dispensing. Well, yeah. Okay. Not necessarily data upon dispensing. The data entry is consistent. You have to get data from the pharmacy, which then has to be put in, depends on the other workload that somebody has to have, and then move forward. So, you may not exactly have the most recent data of the narcotics that somebody has received. Controlled access. For me, in my emergency department and other physicians in Massachusetts, we have a great problem because you have to be a fully licensed physician. You cannot have a training license. At least for a while, you couldn't have a training license to get into the PDMP. So, we see patients at a rate of, the attendings see patients at a rate in the acute side of almost 5 per hour. I don't have the time to go through and churn through the PDMP, and the residents don't either. So it relies on, you have to rely on other things, which I'm going to come back to in a moment. Prescriber and drug information. Well, not all schedules are necessarily included in this. There may be incomplete prescriber information. I may get a name and I may get an address in Massachusetts from where somebody came from, but I don't always get a phone number if I need to reach somebody and ask a question about the patient who comes in. And usability is, for me, I think a major issue with these. These guys are cumbersome in some states, and I'm going to talk about Massachusetts because this was my own little data set. If I start from a blank computer screen till I get to the point where I am pulling up data about exposures, it's 17 discrete tasks that I have to go through online. So, that's done because you have all sorts of protections of confidentiality that have to be built into the PDMP. This data is from Jean Marie Perrone and Lewis Nelson's work, and this is the barriers to accessing PDMPs. And the the gold bar on the left-hand side is time. The reason people do not access PDMPs is because it just takes too long to do so. The blue bar next to it is computer availability. So it's not lack of computers. It's the fact that if you get on a computer, it just takes too long. Some people, the green bar is, I don't think it would change my management. A little bit more on that later. PDMPs, let's see, this is related to outcomes. And this is an arcane piece of language. PDMPs are associated with the mitigation of increasing opioid abuse. That means they don't really seem to do all that much in terms of preventing increased amounts. So this is RADAR's data. RADAR's is drawn from a couple of different data streams, one of which is poison control centers. Poison control centers have enormous problems with completeness of data and accuracy of data. The other data stream is from drug treatment. But it doesn't seem to do all that much in terms of blunting overdose. PDMPs also have not been associated with lower rates of opioid deaths or lower rates of consumption. Now, this is Len Pelosi's work, and this is like a CDC database. It's database work, and database research has its own set of issues that go along with it. But like, the best we can say right now is that PDMPs don't really seem to change dramatically the amount of opioids, overdoses, deaths, treatments, what have you. So to what extent do PDMPs change behavior? Do they change them at all? And I think, yeah, they do, but potentially not all that much. This is a very recent publication out of Annals of Emergency Medicine. And I thought it was interesting, which was emergency physicians seem to be about as good as, yeah, this is your work, if you want to give everybody a wave. Yeah. PDMPs, you know, like, there's not that much difference between PDMPs and clinicians in terms of predicting problematic opioid use. There also wasn't that much change in prescribing behavior. About 10%, there was about a 10% rate of where the prescribing patterns changed. 6.5% of instances people would prescribe more opioids after reading the PDMP. 3.5% of the time they would prescribe less. But yeah, that's not huge. That's not huge numbers. I'm sorry. I think I've got a wrong slide put up there. I've got the wrong title. This is from a 2010 paper by Barron, which found that, you know, like 61% of prescribers would decrease the amount of opioids that they would prescribe. You know, they're personally, I thought both of them are nicely done studies. They're relatively small, but I like small because then I can get, you know, then I can understand them. But you know, the bottom line right now for clinicians is I think that PDMPs are cumbersome. PDMPs may not change your behavior. PDMPs may give you in selective circumstances some information, but in terms of changing population-based behavior, it's just not there right now. I have some people to thank at NIDA, Wilson Compton, and my program officers, Myra Barr and Shoshana Kahana. ONDCP, my ONDCP friends, CC Spitznaz, among others, and then my UMass Toxicology Fellows, and I'd like to thank you for your attention.
We have plenty of time for questions. I want to ask one first. Is there any potential for getting non-physicians who are ancillary staff to access the PDMPs so that, say, for example, a clerk could do that for every patient coming into the emergency room and give you a printout so that you don't have to spend the time doing that?
Yeah, I mean, you know, with the broad number of agencies that oversee the development of them, I don't know that it's possible to give an answer for that. What I can tell you is in Massachusetts, I'd be floored if they allowed that to happen. You know, they won't even let residents in. Why a clerk?
Just changed our laws so that you can designate a person to look it up for you. You have to have like a set practice manager. You can designate one person to use your access information. But they're also accessing it under your name. So Ohio has the same.
Yeah, I mean, hope springs eternal. I mean, it would be the rational thing to do that sort of thing. But you know, like in Massachusetts, I'm just not holding out much hope for it.
Yeah, in Colorado, I think nurse practitioners can also access it, and they actually access it. You know, when you look at registered versus accessing it, the nurse practitioners access a lot more often than physicians, which is great. But I have a question, Ed. So, you know, regarding PDMP, I think those are very well-defined issues that you described that I think have been talked about, the push-pull. What is being done on a national level that you know about to answer some of these questions? I thought SAMSHA and NIDA might have been working together to pool some resources to make the PDMP much more user-friendly. So I'm just wondering.
Yeah, we're fortunate that we have the person in the audience who can answer that, and we're unfortunate we didn't give the talk. Lewis, do you want to answer that? I mean, you're better equipped to answer what's going on nationally than I am.
Well, you know, I'm not sure I have the exact answer. Getting thrown under the bus here. No, you know, I don't, unless you know something I don't know, which you very well might. The problem you run into with all of these things that involve multiple states is states' rights, you know, and practice of medicine is a state-based issue. It's run by state medical boards or state pharmacy boards. So anytime you have interstate cooperativity, it really requires very high-level interaction at the state level. So there's a couple of these PDMP systems. There's a 7-state one involving Kentucky and Ohio and whatever, somewhere in that part of the country. But they've all come to an agreement that they want to do it. Now, what is changing is that a lot of these PDMPs are now being run by contract organizations. as opposed to being run by individual states' departments of health or pharmacy or whatever. As that happens, there might be more talk about organizing these state groups. But to the best of my knowledge, it's going to be a long time off until the federal government is able to take all 50 states and the territories and put them into one prescription monitoring program, if that was kind of what the question was.
Wouldn't that be meaningful use of the PDMP?
You know, it certainly sounds like meaningful use. The problem really comes down to the fact that individual states, the medical boards really run and they act independently of one another. You're right. It would be the best thing by far, meaningfully.
And maybe just because I live in Massachusetts, but our restrictions are so great on the PDMP. Like originally, you could access it only for clinical purposes. You couldn't access it for research purposes at all. And if you tried to punch something through the Massachusetts Department of Health IRB, you found out that they never met or never meet. So it's very thankless in some places, and I'm glad that other places like North Carolina are capable of moving forward. Yeah.
Yes, North Carolina is indeed moving forward in this regard. I'm also from North Carolina, and while our state legislature seems to be in almost every respect bound and determined to push us back into the Jim Crow era, it has been particularly enlightened in some of the new provisions that it has enacted that affect access to PDMP use. For instance, proactive reporting, so that providers will get notification from the system when their patients trip a certain level of repeated access to opioids from multiple prescribers. But also delegated accounts, which I think is going to be an extraordinarily supportive mechanism by which to encourage providers to actually check the PDMP. It just means that once you register with the system, someone on your staff to whom you delegate this authority can potentially look up a patient on the PDMP who's in your office complaining of chronic pain, and so that at the time that you are going to be seeing your patient, you have a copy of the patient's utilization record. So all of these things are, I think, exceptionally good, but I would like to make one more pitch, which is when you get a call from a pharmacist who says, I wonder if you check the PDMP and about this particular patient. I'm here, she is here trying to fill a prescription. I am concerned that, please take the call. There's a lot of pressure not to take calls, a lot of opportunity to say I'm too busy. These pharmacists are also checking the PDMP, and they need to be heard when they have a concern.
Thank you. Yes, Ed.
I'd just like to make one comment in behalf of the PMP. And even though I find it very clunky and at times frustrating because it doesn't have up-to-date information, we've had a number of incidents, I think in the last month, where just presenting the results of the PMP objectively with the paper to the patient had a positive result. So in other words, here's 100 Percocets that you got last month, 100 Percocets you got 2 weeks ago, and the patient would say, well, I never filled the prescription. I said, you know, we say, well, you obviously filled the prescription because this data only comes when you fill prescription. Patient picked up and left the emergency department. So I'm not saying that's a good thing to have our patients leave, but there are other examples in which we've negotiated treatment for people. So I think that there is the potential there. I think we haven't realized it yet.
You should have had a team of research assistants get them on like an Indy sports car, you know.
Hi, I'm Chris Griggs. Thanks for the shout out about the article that we just published in the Annals. One of the interesting things I found while we were working on the data on this article was the fact that I feel like once you get the data from the prescription monitoring program, there's still a lot of bias that goes into interpreting that data. There isn't a good guideline exactly about how we're supposed to take this data, disseminate it, and then make actions on it. And I had a lot of the people who participated in the study come to me and say, you know, I don't know if I really trust this, and they would give me reasons for why. Well, if patients only pay cash, then their prescriptions don't come up in the database because there isn't a general understanding about how these PDMPs work among, I guess, even academic physicians that I was working with in the study. So I think one of the questions that we have to ask is exactly how are we going to use this information in making our prescribing decisions, and how are we going to disseminate information on the biases that may exist from decisions we make about prescribing.
Thank you. Thank you all for your time.